Hey everyone, Val here. So you could just feel the energy in the room at the NTOCC Washington, D.C. Summit. Doctors, pharmacists, nurses, case managers, hospitalists, policymakers, all talking about the same thing, getting the handoff right. So I sat down with three powerhouse members of our Transitions of Care Pharmacy Committee, Tina Lipscomb, Mary Lombark, and Tricia Cash, right after the session was wrapped up to capture their first reactions, what stood out, and how their own organizations are turning ideas into action. Let's jump into that conversation.
Welcome to the Relay, sponsored by NTOCC. This is Val Emmons, and I've got some of our Transitions of Care pharmacy members with me. We're gonna. I want to see what you guys thought about the summit. It was great to me, in my opinion, but I want to hear what you guys have to say.
Thought it was really great. I love the energy of the group, and the brain power in one room with such passion was phenomenal.
Yeah, the innovations that were discussed were just so refreshing, and to hear all the way from the high up of CMS level, all the way down to trickle down to like what's actually happening in clinical practice. It just gives you so much energy to go back to your day-to-day work and try to implement these things that we talked about in Transitions of Care.
Yeah, someone who works in the trenches, it was really neat to hear about from CMS and all the different agencies and all the impact that's going on.
So introduce yourselves, first of all. I've got
Tina Lipscomb, and I am a manager in case management. I'm actually a nurse, so I'm an honorary pharmacy member as a nurse, and I work at Duke University Hospital.
And I'm Mary Lombark. I'm a transition of care pharmacotherapy specialist. It's just a fancy way of saying a pharmacist that practices in transitions of care out of Tampa General Hospital down in Tampa, Florida.
And I'm Tricia Cash. I'm a pharmacist that works at Frederick Health Hospital, working in Frederick Integrated Health Network with primary care providers and working with patients in transition and other areas of their care.
Okay. And so, I got you here because I just want to get each of your, just do a short answer if you want, your perspective on how each of your employer views this role in improving care transitions across the healthcare ecosystem. Like, what do you view your specific role, personal or organizational?
Well, I'll start in the fact that I probably wouldn't have a role if my leadership and my employer didn't value the importance of transitions of care. I'm not practicing as an inpatient pharmacist. I'm not practicing as a community pharmacist. I truly am embedded in my healthcare system to help improve patients' care transitions from hospital to home, hospital to facility. So I think that speaks volumes that they're willing to implement full-time employees to do this big mission.
And how long ago did that start, though?
So my program that I'm with currently is in its infancy. It's been around for about 4 years. And so I actually just finished up my 1-year anniversary with them. Prior to that, the previous health system I was at, I'd been there 8 years. So doing transitions of care.
Awesome. Tina?
So I come from the hospital and the nurse case management perspective, and we are obviously, like most hospitals are, very focused on managing our length of stay. So transitions of care is obviously a key component of that role because we want to successfully get the patient out of the hospital. And emphasis on successful because we want that patient and family, wherever they go, to be successful at that next level of care. So there's an immense focus on the collaboration of the whole multidisciplinary team, the pharmacist being an integral part of that team to make that successful transition out of the hospital.
I love that you use the word successful, right? Like we can get patients out of the hospital, but can we successfully get patients
without them coming back
home, right?
And part of that success is not only keeping them out of the hospital, but are they doing well? Are they succeeding wherever they are in that next level of care? Are they doing well? Are they within are they meeting are they within their own goals of care, like being at home or wherever they may be? Are they happy? And I know happy is kind of a subjective word, but we do want patients to be successful and happy in that next level of care.
Great point. So I've been with my hospital system since 2012, and I started out in care transitions in the hospital role, working with discharges from the hospital setting to either nursing home or home. And I have been with my current position, which is embedded in primary care practices through a program called Maryland Primary Care Program for about 7 or 8 years. So I'm doing very similar types of things, but in the physician's practice. So working with those patients to make sure that they are integrating into the community well with social workers and nurses. So it's a great job.
I just got a couple more questions for y'all. So maybe you can share how you or your organization, per se, collaborate with other providers and health systems, let's say, to support, better outcomes during post-discharge period, like especially like Dr. Ling was talking about the high-risk areas. You might want to take that one.
So what we try to do is if a patient's in the hospital, the first thing we want to do is get to know that patient and family. And as we start to look at their discharge plan, we have case conferences where we bring the entire team together to actually talk about, after that patient and family, what are their goals? Are they going to go to a rehab center? Are they going to go to a skilled nursing facility? Are they going to go home? And then we make sure that we've got the entire team's input about what they're going to need to leave the hospital. And then we try to make that transition to that next level be as seamless as possible, so that we do the work and the patient and family see very little of that work, and it's just seamless to them.
Anybody else?
Yeah, I can speak to. So again, I practice in the concept of a patient going from hospital to home or hospital to a facility. One of the biggest barriers is making sure the receiving facility understands everything, gets the correct medication list. And so at my institution, we work very collaboratively to do a nice handoff. Not only are we getting case management notes sent to them, but they're getting a full discharge summary. They're getting a discharge medication review from transition care pharmacist. And then we also even employ geriatricians that actually go into the facilities to round on those patients to make sure that transition was successful.
Wonderful. So I work as I mentioned in the primary care realm, but I work with the pharmacists that are still embedded in the hospital system through either notes or through just personal communication with the handovers from there. And then it's a little more difficult with long-term care when they're discharged from there, but try to engage with the facilities as well once people transition from there to home.
I think all three of us really care a lot about the outcomes for our patients and families, because we've either had our own personal experience as a patient or our own family members. And so it's so important to us to know that what we do well.
Let's get to this question, because I know this is on everybody's mind right now. Because, 3 years ago, we weren't even thinking about this. We were like, what? What is that? And now, what is your perspective regarding AI? Aligning those innovations with real world needs of patients, not the ones that are on a piece of paper. Those aren't the needs that are on a piece of paper are not the same as the real world needs of those patients and caregivers during the transitions of care. So how do you feel about integrating AI? What's your take on that?
Well, I hope it will be used as a tool, right, for the clinician, for the healthcare professional within our healthcare industry is hoping where I see it. I'll speak to something that's in its infancy right now at the institution I'm at, is that we are using AI to be able to better tell us if our heart failure patients qualify for heart failure medications that are guideline based. And if they do, then what a better opportunity to start them on medications in the hospital where they're being looked over and cared for, make sure those medications are going to work, and then hopefully set them up for success to go home on those guideline directed medications.
And I'm really hoping, I'm hoping that I'm going to see more and more AI used as a tool to help us in our jobs. And one thing that, not in the hospital, but in the primary care setting, that we've already seen within our healthcare system is the primary care physician can actually use AI to generate the note, so that provider doesn't need to sit there and actually type in their computer. They are 100% focused on what the patient in front of them is saying, or that family, and AI does the work. The provider still has to review the note, and of course, but the AI has been very on target with picking up on even subtleties that I would never have expected it to. So I'm excited for the future of what AI can offer for our families and patients.
I agree. I think AI does have a role, and I think a lot of high-tech things that are coming down the pike will really help with patient care. But I also think that high touch that we have with patients is still critical, because it may look great on paper, but it may not be what's really going on in the real world with the patient.
Right. That would be my hope, right? That it supports allowing the clinician to get back to being in front of the patient, being there with the patient instead of them having to type away on their computer. And I've had multiple times when my family members have come back from a doctor's visit and said, the doctor didn't even talk to me. He was literally typing away over here on his computer and never even looked at me in the eye. So, we'd love for AI to support something like that to get the clinicians and the providers back to being in front of the patients, right?
That's basically what everyone has kept saying, and I'm glad that it's a tool, and you have to have that human touch still, and you have to have a person reviewing, because like we've said, in meetings and stuff like that, like if the input's garbage, the output's going to be trash too.
Right. Garbage in, garbage out, right?
So like, I mean, you can't have the information that going into AI for it to learn has to be correct, which is kind of why we were doing this whole thing today with the summit, to help make the roadmap for successful transition care.
Absolutely.
So I'm just going to ask you this, and I'll let you go, because we all know that the industry is moving more towards value-based care. And what do you see your role as when it comes to supporting smoother transitions between those care settings with value-based care versus fee-for-services?
I'll let Tricia speak to that, because
thanks.
that's what I was saying.
So I'm already in a value-based care
You're right.
model. So I have been for, I guess, 7 years now. So it's been beneficial from that standpoint, that there's not a lot of concern about fee for service for my services, because it's already covered in the value-based model. So it hasn't impacted me in a negative way, probably in a positive way. So, yeah.
Yeah, I would agree. I mean, my job is funded through, knowing that this is the right thing to do from leadership, and hoping to see the better patient outcomes from it, and not necessarily looking for the bottom line number for what I should be billing for each 20 minutes of my day.
Yeah. And I would agree on all of that. And I think that the future of different models that are going to come out of value-based care, that are going to continue to come out of value-based care at a much higher level, are going to just enhance our practice. And our practice is going to get away from those silos, from each of us doing our individual jobs, and more focus on collaboration as a team. And with that collaboration, we're going to see better outcomes for our patients.
Yeah, absolutely. I think Sherry said it best. Like, it takes a village, right? We know that it does.
It does.
Yes, it does. Well, ladies, I want to thank you, and hopefully we will talk to you some more about this. And I'm excited to hear what people have, like social media. People have said they're going to start posting a lot of things on social media about the NTOCC and the summit and the relay. What do you think about that? What did you think about Sarah's presentation too? Because we did not plan that. Like, she sent us her baton. She literally sent her slides to us. And Sherry called me, and she was like, "Did you see Sarah's presentation? Like, she's got a relay race." And I was like, "That is just awesome." It's funny how when a good idea works out and it all comes together without even, like, organically, without you even doing anything. So did y'all get anything out of that? Like, do you think the people in the room did too? Maybe lights came on?
Absolutely, yeah. And I love the name of the podcast, so it's going to be a great venture. We're excited to hear.
I'm excited to see what happens over the next year. So
absolutely.
Yeah. Well, thank you, ladies. I
thank
appreciate
you for having us.
Keep up the good work.
Yeah,
Thank you.
Thank you.
Yes, ma'am.
After hearing from our Transitions of Care Pharmacy Committee at the NTOCC Summit, I wanted to dig even deeper into how this work looks from a leadership perspective, especially at a system level. So next up, we're passing the baton, quite literally, to Dr. Sara Panella, Director of Pharmacy at Emory Healthcare. And Sarah's presentation at the NTOCC DC Summit used a relay race as the perfect metaphor for what happens, or sometimes what doesn't happen, when patients move through the healthcare system. We talked about clean handoffs, the role of AI, and why pharmacists are essential to keeping those transitions seamless. Because when the baton fumbles, patients feel it. Well, here's that conversation. We're going to talk with Sara Panella, who is the Director of Pharmacy at Emory Healthcare. Sara, how are you doing today?
I'm doing great. How are you, Val?
Fabulous, fabulous. First of all, I want to ask you, what does transitions of care mean to you, like on a day-to-day level with your position as Director of Pharmacy?
Yeah, so I think for me, I've been in the world of transitions of care since 2011 as a pharmacist, and it really, in the pharmacy world, transitions of care was still really not a thing back then. And when you did use the term transitions of care, a lot of people went to, oh, yeah, pharmacists do medication reconciliation on admission. That is transitions of care. And to me, that is just one small component of transitions of care. Transitions of care is essentially the patient's journey throughout the continuum of care. So while a patient is at home and they're transitioning to their doctor's office, or going from home to the hospital, hospital to home, hospital to home health care, nursing homes. I mean, wherever the patient is going, that is transitions of care. Essentially, it is just that movement, and ensuring that movement is appropriate and that the patient is going through their care journey seamlessly.
Yeah, and you had a great presentation during the summit, and I want you to talk a little bit about it because it was crazy how we did that because you gave us this great presentation and then Sherry sent it to me and I was like, oh my gosh, I have batons. This is crazy. So you want to talk a little bit about how you see that?
Yeah, that was really crazy. So the whole theme of my presentation, and again, totally not planned, was around relay races and passing the baton. And again, kind of going back to what I was mentioning from a pharmacist perspective, is when we look at work the pharmacists do throughout the care, it's very I'm going to use the word siloed, or kind of just very sporadic. So you have a pharmacist who might work in the ER, and they get the medication history from the patient, and then the patient goes to their journey to the floor of the hospital. You might have a pharmacist there, and they're working on giving best recommendations and verifying orders for the acute care stay. Then the patient gets discharged, and then they go to a retail setting. And then you have a retail pharmacist who is working in that setting, and adjudicating and making sure their prescriptions go through, and giving the medications for their stay in the and I'm sorry, not in the hospital, in their homes. And so you have all these pharmacists throughout the care continuum. But the one thing about our profession specifically is that we don't communicate, even with pharmacists within the hospital. So even the example I gave of the ER pharmacist and the inpatient pharmacist, they're not talking to each other. And a lot of organizations don't have transitions of care pharmacists. So that's also a lost opportunity in many places. So the purpose of our talk was really saying, us as a profession of pharmacy, we really need to do a better job passing the baton off to one another, and making sure that we relay or provide information to each other about what's going on in the patient's care specific to medications. And during the presentation, it wasn't really a PowerPoint driven presentation from the aspect of us reading from slides. We actually had videos. And really, that's what drove the conversations that we had at the summit. So one of the videos was this perfect handoff. It was these two track and field runners. One was running with a baton, and he was coming up to his counterpart. The other one started run also, and it was the cleanest handoff you've ever seen between the two of them. And when we finished that video, I had asked the audience, I said, what do you take away from this video? And everybody mentioned what they saw. And what was interesting to me is, in a room full of folks from different disciplines, clinical, non-clinical, everybody found something different. And so one of the things, and I found that interesting. I thought everyone's going to say, oh, the person in the front started running first, and that really says, like, we need to start getting ready for a discharge before it actually happens. But there were so many other things that people were picking up, saying, you have to understand the person behind you. They noticed that the person in front didn't even look backwards. And I was like, wow, I didn't even notice that. And I've watched this video
One,
countless times.
yeah, the one that I liked, the comment that I liked the best was the one where the woman was saying that neither one of them let go of the baton
Yes.
until the handoff was completed.
And they actually held the baton together for a little bit of time. So in order to do that, that's a huge skill set. You're basically lock in step with the person in front of you while you're running together. I mean, can you imagine being that close to someone running side by side while having a baton in your hand? I mean, that's a skill. And you're right, that one really did stick out. So it was really impressive what a lot of people saw, and that was the example of a good transition. The second video we showed was one that was a pretty much fumbled transition. And it was actually a really funny video. I'm pretty sure it was a high school relay. And, the runner was coming up and he basically tried to hand it off to the guy in front of him. The guy in front of him really wasn't ready. He started to run, he fumbled the baton, and then the guy who in the back who had the baton picked it up and threw it to him, and then he started running.
Yeah, that one was.
And yeah, I mean, it was, and someone might take it from it. Well, he had the baton and he started running, but one of the things was the guy in the back was actually ahead. He was out front, he was in first place, and then this baton fumble created their team being second or third and showed the inefficiencies. And that's really where we are in a health system right now is we have a lot of we might be handing things off, but the handoff is not pretty. We might say, okay, we are, I've fixed all the inpatient problems and now they're getting discharged. Okay, not my patient anymore. This is now the outpatient side. I did my discharge med rec. The meds are all, cleaned up and fine, and we're ready to go. I think that is from a pharmacist perspective how I saw it, and a lot of people. I think that one stirred up a lot more conversation than even the clean handoff because I think everybody felt that one in their soul when they were watching that video.
Well, I've said on the other interviews that I've done, and I've noticed this as just being I mean, I'm not clinical. I'm just a basic patient myself, and I've been a caregiver, but I don't notice a good transition. I notice a bad one. And if it's a good transition, you won't even know there's a thing such as a transition. But if it's a bad transition, oh man, everyone knows it.
Yep. I will
So,
never forget, there was even a time when I was a patient and I actually got discharged, and I'll never forget this. I was actually at the elevator with my mom. We were walking out the hospital because I've already been discharged. And even I'm in healthcare, and I was a little confused about what my next steps were. And the doctor ran after me and he was like, "Oh, I forgot to tell you. One of your labs came back as such and such and such and such." And I just looked at him baffled. I was like, I'm already discharged, sir. And he's like, "You're going to need to make an appointment with this kind of doctor." And I'm like, and all I could think of is, thank goodness I understand what's happening. But I feel like the majority of people who utilize health systems don't have that luxury. And and this is why it's super important that everybody kind of gives that thumbs up check off point to say we are ready and set to let go of this patient, be in lockstep with the next steps for this patient once they're out. And not to say, okay, you're out of the hospital, good luck and good riddance, but really say, hey, you're going to go out and the next provider is ready for you. And I think that to me is really one of the most important things. And that is not just your physician, that is your pharmacies, that is your home healthcare agencies, whatever discipline is taking care of you in any way, shape, or form, that they are ready for you. And that to me is the most important and efficient way to provide transitions of care.
so what do you see as the biggest misunderstanding about pharmacists in the role of transitions of care?
There's so many. I don't know where to begin. I think even within health systems, a lot of people really do not know what a pharmacist should be doing, especially in transitions of care. I think if you go to different health systems, pharmacists are performing quote unquote transitions of care, but what that transitions of care service looks like is very different across the board. Some pharmacists are providing, like I said, admission medication reconciliation. Some pharmacists are not doing any of this work. Some pharmacists, people think, okay, wait, I have a pharmacist in the hospital. I only know of my pharmacist that works at my local pharmacy or even these big chain pharmacies. And I think that people devalue what a pharmacist can do because of the global perception of pharmacists is not really something that is great. And this is now I'm kind of talking more about the public. The public thinks of pharmacists as lick, stick, and pour. They're the ones who fill my medications. They take my doctor's orders. I was actually just on a thread recently where I saw several comments about pharmacists being out of step for educating a patient on a medication. And they're like, that's not their role. That's the doctor's role. If the doctor wrote in, that's what they said it's for. That's what they said it's for. And and to me, I don't know how to be quiet. So I stepped in and I was like, no, pharmacists are med experts. If they had concerns, they're the ones who should really bring it up. You should see the mistakes that we see come through on prescriptions. Like we are a fail-safe measure to ensure safe prescribing of meds. And so I think that that's really where there's a lot of misconception and from both ends, from both how can we utilize a pharmacist, but also from the public perception of pharmacists.
So with that, we're hitting on a little bit on interdisciplinary collaboration. How does Emory Healthcare, what does effective communication between pharmacists, physicians, and nurses look like in Emory Healthcare system?
Yeah, so in full transparency, I'm actually fairly new to Emory Healthcare. I've been there for a little less than 4 months, but the pharmacy team at Emory is such an amazing team, and it's so well established there, so well respected. I have to give really big kudos to the pharmacy leaders there that have helped establish programs that have existed for several years, but it is very collaborative. I think pharmacy is very well respected within Emory, and we have a seat at the table. They know that we bring a lot of knowledge and expertise around medication use and proper use, and also how can we collaborate together to improve patient care. It is quite amazing that they are ready and willing to provide or I should say use pharmacists to the top of their license to do drug therapy management where pharmacists are the ones managing medications in regards to so the way that it works is a physician might say, okay, this patient has diabetes, I'm going to start them on this medication and this is the goal I have for this patient, and then the patient is handed off to a pharmacist to help get them to that goal, and in those really small tweaks of meds, going up on a dose, going down on a dose, maybe switching medications to just get them to that goal. And it helps free up that physician. And so those are some of the very high level things pharmacists are doing at Emory. And I think that we have really established ourselves as part of the care team, and to the point where I feel like we get calls every single day saying, okay, I want a pharmacist in this clinic. I want a pharmacist in this clinic. And we can't keep up with the request.
Oh, wow, that's awesome.
Mm-hmm.
So moving over to a little bit about technology and AI. So are there areas, like I've been asking everyone this, are there areas where you think AI or predictive analytics could help pharmacists identify like high risk transitions of patients earlier? Dr. Swat and I talked about in the very first episode of the relay, we talked about how it would be nice if community pharmacists got a heads up. Okay, this patient's leaving the emergency room, and because you all don't get any information if they're not in the healthcare, the hospital.
Right.
So maybe some collaboration between the community pharmacist and the hospital pharmacist. I don't know. What is your take on that?
Oh, that's much needed. And I think that is a major pitfall or just like a dark hole within our healthcare system is really that transition between hospital or any care setting to the retail pharmacy setting. And the way that we create those relationships and communication, I think, is through developing relationships right now. So it's very pre-technology. It's just knowing your local pharmacies and saying, "Hey, here, I heads up, I have this patient coming," or if you know this patient is involved with a retail pharmacy and very well, and they're well set up there, a lot of it's manual. Um, Going back to your AI question, I think that there's technologies that help hospitals and health systems understand, and not necessarily AI based, but have these systems understand what's happening in the retail pharmacy space. But I think there's a lack of maybe incentive and lack of development of AI from that will support the retail space understanding what's happening with their patients in the health system and outside, and what's going on with them. Are they being admitted? Did they fill out a different pharmacy? And I think that that is where there's there's a lot of pitfalls in patient care because there's so much siloing between these various areas. So I do think that there's stuff that can happen there. I think in the predictive modeling space, there's a lot of technologies that already exist from a predictive analytics standpoint of who's high risk, who's likely to readmit during X amount of time. I think the barrier to AI right now, and I think this is a shared sentiment, is there's so many companies out there that are doing a lot of this work. I know I get reached out to probably couple times a week from a different company. I see demos and they all look really good. And then I've incorporated some in practice and they really are not as functional as they sell it to be. And so I think that there's still a lot of growth in the AI space that's required because patients are not black and white, and the AI is trying to determine factors on black and white data sets and trying to develop predictive modeling around it. So I mean that's just my opinion on it, but I think there's a lot of different opportunities that we can, and growth in this space just overall.
I mean, I agree completely with you. Every patient's different, so you can't really predictive. I mean, you can predict the basic things, but you can't predict each patient. They're so different. But I have another question that is because I have a friend that is in nursing school, and her first couple of years, she doesn't even know what transitions care is. And I'm like, how do you not know that? You're in nursing school. So what do you wish medical and nursing schools taught more about, say, pharmacy's role in transitions of care?
Yeah, oh God, I think that
That's a loaded question.
it's such a loaded question. I'm sitting here being like, woof, I can't even come up with something right off the bat. I have to think about that. I think, when we present, and my knowledge base is really around the pharmacy school training, and I've been very vocal about this, and so I'll kind of touch on that. But I think it does apply for a lot of other spaces, and some spaces do it really well, and I will say that, especially with medical training. When it comes to teaching incoming healthcare providers, and I'm going to use pharmacists as an example, I'm going to look at their postgraduate training, like residency training. And not every pharmacist has to do residency training, but I'm just going to use this as an example. When you graduate from pharmacy school, go into residency training, there's two different paths that you really can go into. One of them is pharmacy practice, and I'm using air quotes if you could see me. And that is so heavily focused on the inpatient side. It's very inpatient focused. But you can also go down a path called community pharmacy residency, which is very heavy retail focused, sometimes specialty pharmacy focused. But we don't operate like that. And then what I always argued is, well, what about the space in between? How are what about teaching pharmacists both and having them be advanced in both areas? Because that's what a transitions of care expert needs, is to really understand very well both the inpatient and acute care side of things, as well as the ambulatory, retail side, clinics going, see patients going to their doctor's offices, chronic care management, they need to see that side too. And so I think that's a deficit in the pharmacy training, and that we really have kind of created this silo, slightly inadvertently. And the argument that they make is, well, there is an ambulatory care rotation that's required for your pharmacy practice, but I've seen some of the requirements, and it still doesn't teach, okay, a patient was in the hospital, they're getting discharged, they can't access their medication. What are you going to do now? Like, that's not a conversation being had on a regular basis. And I think with medical training, they are getting that because they are actually the ones discharging patients. They're actually the ones following up with patients post discharge in the clinics. So if I looked at my physician counterparts, I would give them a lot of credit in saying they do a really good job training there. I think nurses have almost the same problem. I think when it comes to nursing education, and again, this is from just my mind's eye, I'm not a nurse. I will put that disclaimer on here. I think, a lot of the nurses want that acute care experience, and that's where case management kind of came off from. It shot off of nursing because acute care nurses didn't want to do all of the nitty gritty discharge stuff. And so they felt, okay, I don't need to do that. That's what case management's for. And so I think it created this new discipline and it was out of necessity. Nurses don't have the capacity to do all of that. But I think that is why there's just this lack of understanding of a patient gets discharged and they're not really owned by anybody during that time frame. They're kind of in this black hole of care where I just left the hospital. I have a lot of questions. I mean, I don't know about you, Val. Have you ever tried to call into a hospital post discharge and try to talk to somebody? It's not
Absolutely.
easy.
No.
And so I think that's the problem.
But what is the one thing that you need them to know about your role in transitions of care? So if you
I
were
think,
talking to a doctor and nurse, what would you tell them, or in
yeah.
training in school, what would you tell them that your role is? Like, what do you need them to be aware of that you
So
can
as a
do?
pharmacist, I'm there as a partner. I'm there to help make sure I call what the pharmacy does in transitions of care. I look at things from a chronic on acute standpoint, meaning something acutely is happening. I am looking at this patient as a chronic, okay, so what is going to happen with them chronically? And what I do is I'm not trying to be a burden, I'm not trying to be a barrier, but I'm trying to ensure that their care plan that they're trying to implement gets carried through. And I'm part of that process. So I'm, from a pharmacy standpoint, I'm essentially that new care manager or case manager where but instead of managing all of the placement issues and maybe durable medical equipment issues, I'm really focusing on how can I ensure patients are on the appropriate therapies and post discharge, and are they able to access those therapies, and are they able to take those? Is it a feasible regimen for them to take without support of 24/7 nursing? That's my role as a pharmacist. And when I put it that way, I think a lot of people are like, oh, that makes a lot of sense.
Well, with that being said, do you have for the last little closing reflection? Do you have a story or a patient experience that sticks with you as proof that pharmacist involvement truly changes the outcomes? And since we're talking about that,
Yeah, I think I said this one at the summit, and it really is one of it stuck with me. It's one of the most life-changing moments I've ever had, and I know that I changed the life of this patient. There was a patient that I had who was HIV positive and had at the time AIDS. She wasn't taking her medications, and all her levels were really off, and she wasn't doing very well. In addition to, she was an alcoholic. And I worked in an organization that had a really amazing HIV program. But one of the things, and I would round with the physicians, we would see the patient, and the doctors would say, you know, you're gonna die from your HIV and you really need to take your medications. And she wouldn't take anything. She wouldn't take her meds. And I just it didn't sit right with me that that's how they were speaking with her. So after they left, I went on my own and I sat down with her and I said, can you tell me, a little bit more about yourself? And then I finally got to the point of what it seems like you're hesitant to take your medications. Can you tell me a little bit more about that? And what I came to find out is she didn't want to take her medications because she was someone had scared her into had scared her with her drinking and taking the medications, and she is like, I don't want to take my medications because I can't quit drinking, and they want me to quit drinking and I just can't do it, so I'm not taking my meds either. And I said, let me tell you something. What you are likely going to die from the HIV before you die from the two things combined together. So, and then I said, well, what? And she's like, and death, the other thing about it was death didn't motivate her. That was not something that scared her. And I thought that was also interesting. But I said, okay, what does motivate you? And she asked, she's like, my hair. I'm losing my hair. I was like, okay, that's very interesting. So I came up with I mean,
Versus death, she's worried about her hair.
she's worried about her hair, but she's not worried about death, right? So I I came up with a really crazy plan, would not recommend, but it helped this patient is I went to the doctor and I said, I have, this patient drinks a 40 every morning when she wakes up. We want her to take her meds. Why don't I look up if the meds can be crushed and put into her 40 and we know she's going to drink it and finish it. The doctor looked at me like I was mental
Nuts.
and said, you know what? I love that idea. He was like, that is the most innovative, crazy, but innovative idea I've ever heard. So we did research, we looked into it, and I said, yeah, this regimen that she's on, we could do that. So I went up to her and I told her the idea. She was like, what? I think she was blown away that I was like, look, I'm not going to stop you from drinking. I just don't want you to get any sicker. So once we implement, and then I also brought her some headscarves. And I said, hey, how about I teach you how to like tie your hair or tie this headscarf around your head in like this really fun way so you can walk around and not be ashamed of what your hair looks like. No lie. She went 1 year, the year before I intervened on her, she was in the hospital 27 times, 27 admissions. That's not even counting ED visits, admissions. The year following, I think she was in the hospital 5 times. So,
Wow.
and then I remember seeing her on the street. It was a major city. I saw her on the street and she came up to me and when I tell you, I didn't recognize her. She looked so healthy. She had a full head of hair and she ran up to me, gave me the biggest hug. And she's like, you are the one who saved my life. Like I tear up talking about this because you do something simple and doesn't feel like it impacts you, but it changed her trajectory in her life. And it was one of the craziest ideas I've ever had, but I walked away from it being like, I saved that woman's life, which
Yeah,
was
so
really fun.
as opposed to her dying, like you said, you're more apt to die from the AIDS than you are from this crushed up medicine in your beer.
Right.
So that's
Exactly.
where people
Exactly.
need to get more innovative and, of course, do the research, but like you did. But yeah. So that's a great story, Sarah. And I want to
Thank
thank you
you.
for coming and spending time with me today. And I'll let you get back to your day. I know you're busy. You've got
Uh,
your kiddos probably.
yes. Yeah. Got to pick them up soon. So
Well, thank you, Sarah, and we'll be in touch, and we'll have you back on to talk about some Medicare.
absolutely. Anytime. Thank you so much, Val.
And that wraps up this episode of The Relay, brought to you by the National Transitions of Care Coalition. A huge thank you to our guests, Tina Lipscomb, Mary Lombark, Tricia Cash, and Sara Panella, for sharing how teamwork, communication, and innovation keep patients safe through every transition, through their journey, if you will. Stay tuned for our next episode, where we'll dive into 2026 Medicare Part D enrollment with Tricia Cash and what some of those changes might mean for patients and providers. I'm Val Emmons. Thanks for listening. And remember, the handoff doesn't end at the discharge. It continues until the patient is thriving at home. It's a relay race.